Okay, I will count down 3 and we will start after that. 3, 2, 1, action. So hello everyone, welcome to our second episode of Westlake Proteomics series. First of all, some good news from our debut. So last time we had 2 platforms for live streaming, WeChat and VHall, and about 700 audiences attended the webinar, which is a good record for the first episode of an academic lecture delivered in English only. So a massive thank you to our audiences, and we wish to have your continued attention and support. So our webinar continues today with the theme of proteomics and thyroid. We are honored to be joined by 2 speakers and 3 panelists. They are speakers Professor Kenichi Kakudo. Hi, Mr. Kakudo. Yeah, you are dressed in a very nice suit today. And Dr. Yao-Ting Sun. Hello, Yao-Ting.
Hello, everyone.
And we have 3 panelists, Professor Oil Lian Kun from Singapore. Hello. And Professor Zhiyan Liu from China. And Professor Tian. Hi, I'm Professor Tian Guo from the Westlake University. Okay, let's give a big hand. Yeah, let's give a big hand to our 5 distinguished guests. And now let's proceed to the first speech delivered by Professor Kenichi Kakudo. He is one of the authors of book chapters in the WHO classification of tumors of endocrine organs, founding member of the Asian Working Group on Thyroid, Cytology, Pathology, and the International NIFTP working group. And he is also a core member of the Japan Consortium for Juvenile Thyroid Cancer, as well as the general manager of the Cancer Genome Center and Thyroid Disease Center, Izumi City General Hospital, and a visiting professor of Department of Pathology in Kingda University of Japan and Shandong University and Shandong First Medical University of China. And now, let's start Professor Kakudo's lecture entitled Low-Risk Neoplasms in the 5th edition WHO classification of thyroid tumors.
Thank you for inviting me to the great country of China. My name is Kenichi Kakudo. I'm a pathologist specializing in thyroid disease and the author of the books shown on this slide. The title of my lecture today is Low-Risk Neoplasm in the 5th edition WHO classification of thyroid tumor. This table is from the 5th edition WHO classification of thyroid tumors to be published this year. Because of time limitation today, I will focus on low-risk neoplasm. It is divided into 3 tumors. They are non-invasive follicular thyroid neoplasm with papillary-like nuclear feature, NIFP, thyroid tumor of uncertain malignant potential, TTMP, and hyalinizing trabecular tumor, HTT. Eminent epidemiologists alarmed over diagnosis and over treatment of indolent thyroid carcinomas since the 2000s. It is because the incidence of thyroid cancer increased dramatically in recent years, but the mortality rate was stable, unchanged. The 3rd edition WHO classification for follicular variant PTC state approximately 1/3 of the tumor are encapsulated. Despite complete encapsulation, lymph node and rarely hematogenous metastasis can occur. However, the prognosis of these tumors is similar to that of usual papillary cancer. As a result, many patients are negatively affected by this incorrect statement. There were annually more than 40,000 patients worldwide, and most patients underwent total thyroidectomy and radioactive iodine ablation, resulting in overtreatment. My research group proposed a borderline tumor category in thyroid tumor classification to solve this problem in 2011 and 2012. We have proposed well-differentiated tumor of uncertain behavior to replace cancer terminology, non-invasive, encapsulated papillary carcinoma, follicular variant.
Oh,
In 2015, an international working group for re-examination of encapsulated follicular variant PTC was conducted by Professor Nikki Horoff at the University of Pittsburgh. We have collected more than 200 cases of encapsulated follicular variant of PTC from 13 medical centers in 5 countries. The histological samples were examined by 24 pathologists, and they were divided into 2 groups, non-invasive and invasive. Neither recurrence nor metastasis was noted in 109 cases in the non-invasive group with 14 years follow-up. On the other hand, 12 patients in the invasive group developed recurrence, and 2 of them died of thyroid cancer. A new term, non-invasive follicular thyroid neoplasm with papillary-like nuclear feature, NIFT-P, was recommended to replace the term cancer. In 2015, soon after publication of the NIFT-P proposal, the 4th edition WHO classification of thyroid tumors established a new borderline tumor category containing NIFT-P, UMP, and hyalinizing trabecular tumors. However, problems were not completely solved yet. Western medicine has played a significant role in establishing standardized diagnostic approach to disease and optimal clinical management of patients. For thyroid pathology, most practitioners follow international pathology diagnostic system developed principally by Western authors and organizations such as the WHO classification and the clinical guidelines published by Western societies. However, when Western systems are implemented in Asia, Asian pathologists often produce different results from those seen in the West, which will be emphasized in my presentation today. There are several debates in thyroid pathology practice between Asia and the West. The first one is a threshold of PTC-type nuclear feature on RAS-like tumors, which is varied significantly among pathologists. As shown in this slide, there are 2 types of follicular pattern tumors on this slide. Most Western pathologists accept both as papillary thyroid cancer nuclear feature, as there is nuclear enlargement, membrane irregularity, and chromatin clearing. However, most Asian pathologists, like you, do not realize the left image is malignant PTC in Western practice. Asian pathologists accept tumors as follicular variant PTC only when there are free developed BRAF-like nuclear features, as shown on the right. The histopathological diagnosis of PTC is prone to significant observer variation due to different threshold of RAS-like nuclear feature among pathologists. This gap recently widened due to defensive attitude by Western pathologists where malpractice litigation is significant. I found it in 2002, as shown in this table. American pathologists on the left 4 columns reported more PTC diagnosis, as highlighted in red and orange, than Japanese pathologists on the right 4 columns. I believe it is due to RAS-like tumors, whether included it in PTC or not PTC. There are now several more debates in thyroid tumors. Why the prevalence of BRAF V600E mutation in PTC is high, 60 to 90% in most Asian patients, while it was low, 30 to 50% in most Western countries. BRAF point mutation predict a poor prognosis for PTC in Western patients, but it was not reproducible in Asian patients. I believe it was also due to different threshold of PTC type nuclear feature, either in NIFT-P or follicular variant, or follicular adenoma and follicular thyroid cancer. This slide shows the difference in classifying RAS-like tumors. PTC in Western country as a follicular variant PTC, whereas in Asian countries, those RAS-like tumors are not accepted as PTC, as shown in the upper field. They are often classified in either follicular adenoma or follicular thyroid cancer. I would like to emphasize one more debate might also link to the observed variation of RAS-like tumors between Asian and Western pathologists. Sin et al. Reported a significant association between BRAF mutation and extrathyroid invasion, lymph node metastasis, and advanced tumor stage at presentation. Several meta-analyses confirmed this observation, but it was not reproducible in Asian patient cohort, including Chinese patient, Korean patient, Taiwan, and Japanese patient. Let me explain the reason why it happened. When superimposing Western PTC on Asian PTC, the non-overlapping part was RAS-like tumors, which are morphologically follicular variant of PTC, accounting for 10 to 30% of the US PTC cohort. They are renamed NIFT-P when non-invasive and downgraded to the borderline not malignant tumor category in the 4th edition WHO classification. The contamination of indolent RAS-like tumors in the malignant PTC category in Western patient cohort explains why the BRAF V600E gene test identifies aggressive PTC more in Western patients. Sin et al. Revised their conclusion recently as follows. A disease-specific mortality risk order of the genetic duet, TART and BRAF, greater than BRAF mutation alone, or TART promoter mutation alone. They are also greater than wild type for both genes. Therefore, the BRAF V600E mutation alone by itself is not a high-risk finding at all. I'm afraid many of you still might have updated belief. BRAF is used as a poor prognostic marker. Let me show you more differences between Asian and Western thyroid practice. We collected more than 26,000 cases of PTC, including 206 cases of NIFT-P. The mean preference of NIFT-T was 0.8% of all PTCs in 9 Asian practice. Two pathologists, Dr. Liu and Dr. Zhu from China, participated in this study and are co-author of this paper. We further conducted a meta-analysis to confirm our finding, low prevalence of NIFT-P in Asian practice, NIFT-P rate varies from 0.1% to 27.6% among 27 studies. When they were divided into two groups, Asian and non-Asian group, there was a significant difference between the Asian 1.2% and non-Asian average 13.3%. The fifth edition WHO classification modified epidemiology of NIFT-P as follows. The incidence of NIFT-P varies between different regions of the world. The prevalence of NIFT-P is much lower in Asia compared to Western countries. There are also significant variation between different institutions within the same geographic location. Most of these discrepancies are related to different thresholds used to diagnose the nuclear feature of NIFT-P. Let me conclude. All prognostic analysis of thyroid cancer before 2017 must be re-evaluated because most clinical guidelines were established based on data obtained from Western patient cohort, where a significant number of indolent RAS-like tumors were misclassified in malignant category. More studies are needed on our own patient in Asia. We have attention.
Okay, thank you, Professor Kakuto, for bringing us the latest and the most authoritative standards and interpretations from WHO. So any comments from Yao Ting or our panel guests? Or questions, comments? Okay, maybe we can save that until the two speeches have been delivered. So now let's come to our second speaker. Our second speaker is Dr. Yao Ting Sun, who was a specialist in our first episode. Yao Ting is currently a postdoc researcher at the Proteomics Big Data Laboratory, or GOMICS of Westlake University, after having completed her PhD at the same university this year. So the title of her speech is Artificial Intelligence Defines Protein-Based Classification of Thyroid Nodules. Please.
Good evening, ladies and gentlemen. Thank you very much for the invitation to share our new studies in the field of thyroid disease. My name is Yao Ting Sun. I am from GOMICS, Laboratory of Big Proteomic Data at Westlake University. Today, I'm going to talk about the proteomic application in the clinic. The title is Artificial Intelligence Defines Protein-Based Classification of Thyroid Nodules. Thyroid nodule is a common disease in the population. According to the statistical data, more than half of the population have thyroid nodules, especially women. Despite of high incidence of thyroid nodules, only 7 to 15% of them are malignant. So don't be worried if you have the nodules. In clinical practice, the evaluation of thyroid nodules usually requires several steps. The doctors will check the several hormones and detect the nodules with ultrasound. Beyond clinical assessment and ultrasonography, ultrasound-guided needle aspiration followed by cytopathology is considered the most reliable pre-surgical method for differentiating benign from malignant thyroid tumors. Although most of the nodules can be identified precisely, there are 10 to 30% of nodules are indeterminate by cytopathology. and the surgery remains the only option for accurate diagnosis. This leads to overtreatment of those benign nodules. To reduce the overtreatment of indeterminate thyroid nodules, nucleic acid-based molecular tests on fine needle aspiration biopsies have been widely applied before surgery across multiple medical centers. The red panel shows the performance of several famous commercial tests which are used in the clinic. These tests achieve high sensitivity and negative predictive values, but relatively low specificity and positive predictive values. According to a publication from Nature Review, the specificity of nucleic acid-based tests substantially varies across studies. This may be due to the inherent limitation of RNA, which is easy to degrade. Moreover, thyroid nodules are usually indolent, harboring few gene alterations. Therefore, there is an evidence need for an alternative method to address this clinical question. Unlike nucleic acids, proteins are directly involved in all life processes and determine cellular and organism phenotypes. Proteins are important components of biomarkers and drug targets. Therefore, we plan to evaluate the thyroid nodules by proteins. In the last few years, our team has developed and optimized a series sample preparation pipelines assisted by pressure cycling technology, PCT, especially for clinical samples. The proteins can be extracted and denatured efficiently under the high pressure. And the reaction of protein digestion can also be accelerated by the technique. This method can process 16 to 96 samples simultaneously in a high-throughput, fast, robust way. PCT coupled with data-independent acquisition mode in the mass spec has the potential for quantifying the entire proteome. This method was further extended to generate high-quality proteome data from FFPE samples. Our findings show that the quantitative correlation between fresh frozen samples and FFPE samples prepared by PCT has a high Pearson correlation. Moreover, the storage years from 1 to 15 years have no significant effects on protein identification. Based on the previous methodology, we designed a proteomic study to stratify the thyroid nodules by machine learning. In the present study, we collected 3 datasets comprising discovery datasets, retrospective test, and prospective test datasets. In the discovery dataset was from a single center in Singapore. We totally acquired 1,724 proteomic data from 579 thyroid nodules through the PCT-DIA-MS pipeline. For each nodule, we detected 3 biological replicates and calculated the average protein expression for each one. Then we got a 2-dimensional protein matrix. We set up a 19 protein panel and built up a machine learning model based on this matrix. To validate this model, we tested on 2 independent datasets. There were 288 FFP samples in the retrospective datasets, which were collected from 3 hospitals in China. Moreover, we also tested the model on 294 FNA samples. They are collected from 9 hospitals in Singapore and China before surgery. The below table shows the detailed clinical characteristics of the study cohort. In this size, the left heat map shows the protein expression for discovery sets from Singapore. Each column indicates a thyroid nodule, and each row indicates a protein. There are 5 types of nodules from the left to the right side. They are normal thyroid, multinodule goiter, follicular thyroidadenoma. These 3 are benign nodules, and the 2 blue ones are malignant nodules. Follicular thyroid carcinoma colored in light blue and the papillary thyroid carcinoma colored in dark blue. It can be seen that from left to the right side, the malignant degree of thyroid nodules gradually increase. More new proteins are identified in malignant nodules, and the proteins identified in benign nodules were more highly expressed in the malignant nodules. The right 3 panels are UMAP plots. Each point indicates a nodule, and they are grouped by histopathology type in different colors. In the first UMAP plot, the papillary thyroid carcinoma exhibits completely different characteristics from the other 4 types based on the global proteome. The second UMAP plot shows the most malignant thyroid nodules can be distinguished to the benign nodules with several overlapping. Then we isolated the overlapped samples. We found they are most from follicular thyroid adenoma and carcinomas. These 2 types of nodules are also difficult to differentiate before and post surgery by histopathology. Next, we build a protein classifier based on Singapore discovery dataset. This figure shows the workflow of our classifier establishment. There were 3 steps. First, we performed feature selection by genetic algorithm to find a panel of proteins for thyroid nodule stratifying. Then we built an artificial neural network model, which contained 2 layers. We self-designed the loss functions and for the proteomic data. And finally, we test the model on 2 independent data sets. By the genetic algorithm, 19 proteins were evolved from thousands of proteins. In the left figure of shape value, the proteins are ranked by their importance and contribution to the model. Then we also map the selected protein features in the global proteome identification ranking plot according to the protein expression abundance. Most of the selected proteins are high abundance proteins, which may be easy to be detected by both targeted and discovery proteomics strategies. Furthermore, we conducted bioinformatic analysis for the 19 selected protein features. Except for the SIAE protein, the other proteins can be directly or indirectly connected in the network. Although we didn't identify the femur thyroid cancer molecules such as TP53, P38, MAPK, and NF-kappa B, they can be enriched in the protein network. And the P38 MAPK signaling pathway is located in the hub of the network. It is also the most significant enriched pathway showing in the Sankey plot. The above result shows the protein features are highly correlated with thyroid cancer biological behaviors. To evaluate our model, we compared our self-designed neural network model with the other 6 commonly used machine learning models under the 19 protein features. The left ROC plot shows that our model achieved the highest AUC value of 0.93. In the right ROC plot, we evaluate our classifier on each dataset. The classifier got more than 0.9 AUC for the retrospective and the prospective independent test datasets. And for the indeterminate thyroid nodules, which are scored with Bethesda 3 or 4 levels, our model can achieve an AUC of 0.89. Then we plotted the benign and the malignant nodules in the UMAP. Using the selected 19 protein features, the two types of nodules can be well separated in both retrospective and the prospective test datasets. The above results indicate our classification model can successfully distinguish the benign and malignant nodules. We also compare our protein-based classifier with the nucleic acid-based classifiers. Our model achieved high accuracy in FFP test datasets and comparative accuracies with serosig in FNA samples. Furthermore, we analyzed the model performance on the specific histopathological types. Follicular thyroid carcinoma is the most difficult type to be diagnosed by our classifier. Therefore, in an ongoing study, we have expanded the analysis of thousands of follicular thyroid carcinoma and adenoma, hoping to obtain more new biomarkers to distinguish them and then establish a new AI model. In addition, we still continue to verify the discrimination between benign and malignant nodules. We quantify dozens of proteins of interest through the targeted proteomics strategy and validated them in a prospective clinical trial in more than 20 medical centers. For this, I would like to close. Thank you very much for the help from all our collaborators. And thank you for your listening.
Hey, thank you, Yao-Ting. And from your speech, we know better about how AI, this very big and trendy topic in the 21st century, can be integrated into the life sciences or medicine. And that is all for our 2 speeches tonight or today, depending on where you are. So before we proceed to the panel discussion, now it is my great honor to present to you our 3 distinguished panelists. And they are Professor Oi Ling Kong, former head of the Division of Medical Sciences, National Cancer Center, Singapore, MBBS, Fellow Royal College of Physicians, Internal Medicine. So Professor Kong was also a panelist for our first episode, and our audiences were really impressed by your insightful interpretation and your elegant and impeccable British English. And our second panelist is Professor Zhiyan Liu, doctor and academic leader of the Department of Pathology of Shanghai Sick People's Hospital, and she has 2 doctorates, one from China and the other from Japan. Professor Liu is the Associate Chief Physician and the doctoral supervisor, as well as a visiting scholar at the University of Michigan. So welcome, Professor Liu. And last, but surely not least, Professor Tianan Guo, the man after whom the lamb is named. He served as a panelist for our first episode as well. Professor Guo is a principal investigator and assistant professor at the Proteomics Big Data Lab at Westlake University and the director of the iMarker Lab. So before the panel discussion starts, I wish to say we have 2 live streaming channels. So if there are some questions, they will be forwarded to the panelists on condition that the time permits, and those panelists will answer the questions from the audiences. So now the floor is yours, the panelists. Thank you.
Thank you. Thanks a lot. Thanks, Professor Kakudo. Thanks, Dr. Yao Ting and Dr. Liu Zhiyan and Dr. Kong. It's a very interesting symposium. We are talking about 2 very different disciplines. I'm very glad to learn so much details about the diagnosis of thyroid nodules, and I have actually quite a few questions about the talks by Professor Kakudo.
Yes.
Professor Kakudo, you mentioned there is a huge difference between the Asian patients and the Western patients.
Yeah.
According to the BRAF mutation, I noticed there are 60% to 90% BRAF mutations, and it seems not very relevant to the mortality. But in the Western data, there are 30 to 50% of BRAF mutation and relevant to the mortality. And you also mentioned this may be due to the RAS-like portion in the thyroid nodules. So can you further elaborate this? I don't quite understand why this is related to RAS-like mutation.
Well, what should I say? We have very heterogeneous diagnostic criteria among pathologists. Dr. Liu and me are working together in the past. Therefore, we know each other diagnostic system. But when you go to the other hospital or other country, you may have some discrepancy in the clinical analysis or research data. Even Dr. Sun's study today, I suspect some problem in the diagnosis of the follicular thyroid cancer or follicular variant papillary thyroid cancer. I'm happy to examine your sample, Dr. Sun, and you can reach more accurate result, I expect, in your study. Anyhow, congratulations to Dr. Sun. I'm very impressed with her study. And my presentation today is going to bring out what is the problem in pathology diagnosis. It is not the gold standard. That's from the pathology side. We have to be careful about pathologist diagnosis because of the different threshold. Dr. Liu, could you help me to explain it in Chinese or English? Because of my Japanese accent. Some people may not follow me very well. I I said there are heterogeneity, differences in diagnostic criteria among pathologists. Therefore, the papillary cancer in Western countries and papillary cancer in China and papillary cancer in other Asian countries like Japan may be a little bit different, not completely different, or probably 80% or 90% are okay. But we have problem in minor proportion of the thyroid cancers. In some cases in Western society, it may be a benign tumor in China or in Japan. That's the point I'm going to explain. And I propose, together with Dr. Liu, borderline tumors, which are malignant in Western society and benign in Asian countries. It is confusing for international thyroid plaques. Therefore, we combined it into borderline. That's the point.
Yeah.
And then WHO classification accepted as not benign, not malignant tumors. And in such a cases, Dr. Sun has a very delicate analysis using proteomics, but in some noise may interfere the elegant result. Dr. Liu and Dr. I myself can help her to more accurate or remove some noises from their studies. Dr. Kohn, you may have any advices to her?
Yeah, you mean me or Dr. Kong? I'm Guo. I'm Tiana.
Oh,
So
yeah. I know you are Dr. Gao. In front of my monitor, Dr. Kon and Dr. Sun and Dr. Liu are in the monitor together with you.
Yes.
Give some explain. In fact, we also analyzed the follicular variant PTC at the proteome expression level. We found the follicular variant PTC was more similar to the follicular thyroid carcinoma
cancer,
and shared a little bit overlapping with the classical PTC.
We still have some diagnostic problem to be solved.
So when I first heard WHO guideline, I think we think this is the gold standard, and the guideline contains knowledge from the leading experts, leading pathologists from the world, as it actually is.
It is a current best classification, should be, but I still have some questions.
Yeah. So and I understand that the classification is mainly based on the morphology, so how the cell looks like, and microscopy, and some molecular diagnosis, like the mutations of different genes. And we know that there are actually maybe at least more than 100 genes has been reported to be mutated, used, or whatever other genetic abnormalities in thyroid nodules. But in the guideline, I heard only a few. I heard the BRAF and RAS and TAT, but not others. So do you think what's the criteria for the WHO guideline to include some molecular dysregulations in this guideline? Why others?
We are now currently working on the 5th edition, the most recent one, which was opened recently online. But it is still non-molecular stage, probably because we have few RAS and BRAF driver genes and TAT promoter genes, but we do not know which one is more significant to the prognosis of the patient? Because some Japanese surgeons recommended observation to a small papillary thyroid cancer, and the patient do not die. Still, pathologists calling it malignant, but biologically, those tumors are not malignant. We have a kind of mystery, unknown genetic events, which gene move or goes to the patient more aggressive clinical course. Is not well solved yet. And Dr. Sun's studies, I'm impressed very much because of the it's a new field to give us a new classification system. But one problem she has is her gold standard is still morphological diagnosis. I think if the prognosis is available, the patient who died of thyroid cancer, it's a most important parameter, I think. Sorry, I'm not good in English.
Yeah, sure. We understand you.
Hi. Ryu Sensei, could you help me? I think pathologists can help Dr. Sun. Hi. Go ahead.
Dr. Liu probably have some network issue. I cannot hear her clearly. But I know what she's saying. She was saying you are speaking very good English.
Well,
very well.
Yeah. I am a kind of a negative person, raising many questions to the current standard of the WHO classification. But I think there are still problems. And it is clear in Dr. Sun's study, there are a few cases which does not fit her classification. It's a kind of outlier. And we have to handle those outliers, how they are, should be removed or should be included or something like that.
Yeah.
To remove the noises.
Yeah. Just now you mentioned a very important point. We are using a pathological diagnosis as the gold standard for study.
Don't believe pathologist diagnosis. there are some problems. Yeah, the patient who died of cancer is okay. It is a cancer, true cancer. The pathologists call them cancer, but many pathologists call benign tumor as cancer because of the invasiveness, because of the nuclear feature, because of the lymph node metastasis. But the patient does not die of cancer and can be followed for long period.
So there's another challenge for the thyroid.
Yeah, I think so.
Most people, they don't die. Almost very, very few people, they died from thyroid cancers. But can we use the metastasis of thyroid cancer, thyroid tumor, as the standard, practical standard for
Yeah,
research?
the definition of cancer has 2 points. One is the invasiveness. Therefore, pathologists call cancer when tumor has invasion or lymph node metastasis. However, the definition of cancer has 2 elements. The other element is neglected. That's a growth speed. Cancer has a growth, unlimited growth, or uncontrollable growth. That is necessary to evaluate. Dr. Sun's study is very important, which can measure or evaluate the growth speed pathologists identify cancer only when invasion exists. Therefore, pathologists has some problem in accurately diagnosing malignant tumors. Did you follow me, Dr. Sun? I think I'm going to advise your next study on the discussion.
Yeah, want to.
Liu is coming back. Could you help me to develop our discussion?
Yeah,
she's my daughter.
Yeah, no. Yeah, thank you very much for inviting me to be here. There are two wonderful presentations tonight, and I'm very glad that I can come across Professor Kakudo here. So there is just several points which I'm very impressed by Dr. Sun's presentation. That the study, according to your study on Thyroid, you got a little higher accuracy than Thyroid verse 3. Yeah.
Yes.
So I found it is not only higher in FFP sample, but also in fine needle aspiration sample. So it's very promising. And I also found that the proteome of papillary thyroid carcinoma are very different from benign and low-risk neoplasia from your study. I believe Professor Kakudo just focused on the diagnostic criteria and the inter-observer and intra-observer variation of our judgment, especially pathologist's judgment of those samples. As to the molecular feature of the thyroid follicular tumors, in the new WHO classification, the tumors originated from thyroid follicular cells are mainly divided into two types. One is BRAF-like tumor, and another one is RAS-like neoplasia. However, BRAF-like is not only BRAF V600E mutation, it also includes ALK fusion, NTRK fusion, RATCH PTC fusion, and also the others, such as RAS mutation, including not only RAS itself, but also BRAF V601E. So that's the point that Dr. Hu talked about. And as to RAS-like tumor, it includes not only follicular thyroid adenoma, follicular thyroid carcinoma, but also very rare tumor or follicular tumor on certain malignant potential, and also some invasive follicular variant papillary thyroid carcinoma with capsule or without capsule. And there are also some, the other point is RAS-like tumor. When we talked about it, it is a combination of morphology and the molecular feature. And when we go to fine needle aspiration samples, it mainly went to Basista group 3 and group 4. So the RAS-like nuclear feature means the nuclear enlarged only a little. It's a kind of size and shape. And it is round rather than oval, and less nuclear growth, nearly no should inclusions, and there should be no plasma bodies in the background. So I believe this type of tumor mainly fall to Basista 3 and Basista 4. Kakudo-sensei, how about your opinion for this group?
Yeah, I think you're correct. RAS-like tumor can be concentrated into Basista 4 in my practice, but in Western practice, it usually found in both AUS Basista 3 and Basista 4. Yeah.
And another one is when we talk about RAS-like tumor and the BRAF-like tumor, we not only focus on the nuclear features, but also focus on the growth structure of the tumor, such as BRAF-like tumor mainly in papillary growth pattern. As to RAS-like tumor, it's mainly follicular pattern. Therefore, the RAS-like tumor mainly including those follicular patterned thyroid tumor. As I told you before, mainly 3 types: follicular variant papillary thyroid carcinoma, follicular adenoma, and follicular carcinoma. However, in fact, when we make diagnosis of follicular carcinoma, we mainly went to, firstly, the nuclear feature, especially the papillary thyroid carcinoma type nuclear feature. When there is no PTC type nuclear features, we will go to follicular tumors, including follicular adenoma and carcinoma. And when we judgment the invasiveness of follicular neoplasia, we mainly focus on the capsular invasion and the vascular invasion. However, as we know, there is one new type of follicular variant, follicular neoplasia in the WHS classification addition 4th, which is oncocytic carcinoma or oncocytic neoplasia. The diagnosis criteria of those tumors are nearly the same, including capsular and vascular invasion. However, there are still inter-observer and inter-observer variation on those invasion. Competencies also lead us on these 2 types research on capsular invasion, and Dr. Zhu published 1 paper maybe last year or the year before last year. Yeah, we are still we are still working on the vascular invasion, because when we go to the vascular invasion of follicular neoplasia, we need strict criteria. However, there are still differences on this criteria.
As Dr. Liu emphasized, we pathologists have some problem, and which causing some noises to Dr. Sun's study. Therefore, the accuracy can be polished more. I think Dr. Liu and other pathologists in your institute will help you to exclude or include some problematic cases. Yeah.
Yeah, it will be helpful. And I have questions for Kakudo Sensei.
Hi.
Can you hear me?
Pardon?
Yes.
Whether there are some relationship between the nuclear morphology and the gene mutations, such as BRAF mutation.
Yes. This is another point. I think we can reasonably distinguish BRAF tumor and RAS-like tumor using only morphology, but I'm sure molecular study is highly sensitive for those studies. And therefore, Asian pathologists usually identify BRAF tumor more accurately and classify it in AUS and SM category, Bethesda 3 and Bethesda 5. And therefore, on resection, many patients have a PTC, classic type PTC of BRAF type in Asian patient cohort. While in Singapore, those people trained, pathologists in Singapore are trained in British system usually, and using the UK system probably more. And they have some differences in diagnostic criteria from the Asian pathologists, and they use this AUS are slightly different from the Asian pathologists, and they include some molecular thyroid cancer in AUS category and FN category, probably almost evenly. Well, Dr. Liu coming back. Do you have some comment?
Yeah, in fact, when we mix diagnosis of NIFT-P, which is non-invasive encapsulated follicular variant papillary thyroid tumors, we mainly focus on the nuclear features of those types of tumor. And the rule of those types of tumor are exclusive of less than 1% of papillary growth pattern. It means it's mainly a kind of follicular pattern tumor. And then we will focus on the nuclear features of those types of tumor. When we come to RAS-like nuclear feature, it mainly means the score of the nuclear feature is mainly less than 1. So, which makes the score of the nuclear features of PTC? It includes mainly 3 parts. The first one is nuclear size and shape. The second one is membrane irregularity. The third one is chromatin features. And as to nuclear size and shape, it mainly divides into 3 parts, which is nuclear enlargement, nuclear elongation, nuclear overlapping. And when we talk about membrane irregularity, it mainly includes irregular contours, pseudo inclusions, nuclear grooves, and capital Synthese and our Asian working group are just trying to use a scoring system to replace the 3 scoring system.
Yeah.
But
the one Dr. Liu explained is proposed by NIFT-P working group by Western pathologists. And those nuclear features are often seen in the RAS-like PTC, not the BRAF type PTC. And they do not distinguish it very accurately. And recently we have published one paper to distinguish BRAF PTC and RAS-like PTC using histology, not the cytology. And we have reasonably sure we can distinguish it morphologically. Well,
so according to the score of NIFT-P, when the score is about 3, it should be a kind of BRAF-like nucleus here. When it is less than 1, it should be a kind of RAS-like nuclear feature. But it is not always accurate.
Yeah, we are going to study among the Asian pathologist group to establish the morphological change of RAS-like tumor and BRAF tumor. And will be published, I believe. Dr. Chan from Korea is now working on that project. And another Korean doctor is working on that project too.
So how do you determine the RAS-like and the BRAF tumors? Do you test the gene mutation?
Oh, yeah. That's another point. In Japan, molecular test is not covered by health insurance system. Therefore, cases in Japan do not have enough molecular data very often. Therefore, as I pointed out, those studies are carried out using Korean patient cohort because they have gene tests very often. How about Singapore and China? I think you have the molecular data on your patient.
Yes, we have molecular data nearly on every patient.
So that means you can have such a study in Chinese patient.
Yes, in fact, in my practice, I just found some tumor which shows RAS-like nuclear feature, and maybe it has TERT promoter mutation. It should be a kind of follicular carcinoma, but it has a kind of RAS-like nuclear feature. Yeah, there are several cases which are very interesting.
So for Dr. Liu, normally
maybe Professor Guo can get a very promising data on protein on those kind of lesions.
Yeah, we can collaborate in that regard. So Dr. Liu, normally how many genes do you measure in your hospital?
Sanger sequencing and qPCR.
Yeah, how many genes?
How many genes? Mainly 8 genes, no,
8 genes.
including BRAF, RAS, TRK, RET, TERT, but not P53.
Oh, okay. So can Prof. Kong comment from the Singapore part? You are following a UK system, is it? Is it Asian patients, Asian doctors following Western training and guideline?
Well, thank you, Tianan. I mean, I appreciate the invitation to participate in this panel discussion. And I'd like to thank Professor Kakudo because you've done us a great service by shining a light on the problem with the diagnosis of NIFT-P.
Thank you.
That's something that needs a wider discussion and a thoughtful discussion. I think all of us probably understand the rather short history of NIFT-P. It was proposed as a new histological subset of thyroid tumors, which was designed initially to address the problem of overtreatment of thyroid nodules. But in the last 5 or 6 years, I think it's become clear that although the original intention may have been good, the implementation of NIFT-P diagnosis in laboratory, pathology laboratories throughout the world has been very problematic. And as Professor Kakudo has highlighted, there's a great discrepancy between the apparent prevalence in Asia versus Western countries. But if you do a literature search of NIFT-P diagnosis, you realize that this discrepancy, in fact, exists in many countries. And even within North America, different pathology laboratories, different pathologists are making the call of NIFT-P at different levels. I think Professor Kakudo has emphasized the fact that perhaps a large part of this discrepancy is caused by the fact that different pathologists in different countries and different institutions within the same country are using different thresholds of applying the diagnostic criteria. Personally, as somebody who is more on this thinking about the molecular biology of thyroid tumors, I think this current status of discrepancy, of the lack of agreement, I think that's in fact a considerable intellectual and scientific problem for at least 3 reasons. Personally, it's my view that we need to, first of all, establish whether the discrepancies that are observed are entirely due to intra and inter-observer differences. Because if that's the case, then it may be possible for pathologists to develop objective, quantitative criteria that do not depend upon personal assessments. And this may be where artificial intelligence has a role in identifying hundreds of thousands of images. But I also wonder whether the differences in prevalence may not be simply the result of different thresholds of diagnosis, but may also give us some insight into whether there is a real difference in the epidemiology of this class of so-called low-risk follicular neoplasms. It's obvious that there are external risk factors for thyroid cancer. We don't know every one of them, and there may be some that we have yet to discover. I think the other problem, apart from the knowing the true epidemiology, the second intellectual and scientific problem has to do with the kind of work that Dr. Sun has presented. because people like Dr. Soon are relying on the histopathology diagnosis. And if that is variable across countries, that contaminates the protein or the molecular genetic data. And I think that's an important point to be aware of. The third point that I'd like to raise is this question of overtreatment. And I know that if you read the literature in the field, everybody mentions overtreatment as a problem. I would like to suggest that for the doctor and for the patient who's sitting in front of the doctor, the issue is right treatment. Perhaps we should be thinking more about right treatment, because we shouldn't overtreat, but neither should we undertreat. And I think the alleged benign behavior of the NIFT-P tumors may not be entirely correct, because there are uncommon instances of patients whose tumors were diagnosed as NIFT-P, but who ended up dying of the disease and having distant metastases. So I think we need to be a bit cautious of this new category. I think there may be some merit to the new category, but I think there's a lot that we still do not understand about it. And looking at the overview of the 5th edition of the WHO classification of thyroid tumors, you know, I'm kind of left to wonder, as a non-pathologist, but as somebody who's interested in trying to understand the biological behavior of thyroid tumors, whether in fact it is very helpful for pathologists to make thinner and thinner slices of thyroid cancers. I mean, do these new categories, these new slices, we're kind of slicing the pie into very small segments now. And my question is, for the purpose of the patient and the doctor who needs to decide on what is the best and right treatment, is having multiple categories really helpful, or is it in fact confusing? And I'd like to suggest that from my reading of the literature, NIFT-P has probably confused the field rather than clarified the field. But it may be that it's too early, but it may be it's, you know, it's not yet a decade. We've not had a very long experience of using NIFT-P, but I think currently I don't get the sense that it's been a very useful category to have in mind, both for research as well as for clinical practice. But I really do hope that this discrepancy will be resolved one way or another, because without it, I think we'll get data, first of all, that cannot be compared, Asia versus the West, because we're really looking at different things. And furthermore, by not resolving this discrepancy, I think we are denying ourselves of the opportunity of making new discoveries, simply because we're not talking the same language.
Thank you for your comment, Dr. Kohn. Yeah, I agree most of your discussion point. And one point I'd like to come back again is we have different approach to the this kind of borderline tumors. In Western society, NIFT-P is a surgical disease. They recommend surgery, not a malignant tumor. They recommend surgery because it is a borderline tumor, and it has a driver gene RAS mutation, and they suspect it may develop progress or metastasis in very rare occasion. As you said, it is a safe option to take it out. That's a Western policy. Probably Singapore is involved. However, in Asian society, other poor, underdeveloped society, medical science is not well developed, and society cannot afford such a kind of safe options. Therefore, in Japan, NIFP is not a surgical disease at all. We observe it, and no problem occurred in most cases, probably zero at this moment. Even malignant disease, small papillary cancer is observed about half of the practice. I mean, in Western society, small papillary cancer undergoes surgery, about 50% of thyroid surgery, thyroid malignancy. But it is less than 20% of thyroid surgery in Japan. And we do not have increased mortality, even observing small papillary cancer. Therefore, we are confident we can observe NIFT-P without surgery because it's less than malignant disease. But Western people does not accept such a dangerous options.
I understand, and regrettably, the atmosphere for surgical practice, clinical practice in Western countries, especially in the United States, it's a very litigious society, and there's a lot of defensive medicine, and that probably has influenced the way thyroid nodules are treated. But I wanted to take up Professor Kakudo's point about surgery. When Dr. Go and Dr. Soon began this study on the proteome of thyroid tissue and thyroid nodules and thyroid cancers, one of the important objectives that we had in mind was in fact to avoid surgery, which is exactly what's happening in Japan.
Yeah, that's what I'm emphasizing, how to avoid surgery.
Exactly.
Even it is lobectomy, limited surgery.
Exactly.
Yeah.
So the whole purpose of looking at FNA biopsy samples was to say that could we predict with great accuracy and precision at the fine needle aspiration stage what the future of this nodule would be. I think that was our aim, as I understand it. And it's very interesting that the complete diagnosis of NIFT-P, in fact, does require surgery.
Yeah,
Now,
that's right.
I'm not sure.
Therefore, NIFT-P is very few in Japan and in China. Probably in Singapore, it will be a little bit higher.
But, you know, I think it should also be pointed out that surgery is not benign. If you look at the adverse outcomes of thyroid surgery, it's not trivial, especially in centers that are low volume. The complications, and I'm not talking about minor complications like a wound infection. I'm talking about things like permanent damage to the recurrent laryngeal nerve. I'm talking about permanent hypoparathyroidism. In some institutions, the prevalence of such serious complications and permanent complications can be as high as 20%.
Oh, yeah,
so I don't think
it's a tragedy.
I don't think that we should regard surgery as being non-invasive. It's not only invasive, but it carries risks of its own. And that is why we are working towards getting to the stage of the FNA biopsy tissue and trying to be very precise and accurate so that the patient can be told very clearly, this is a green light, this is a red light, or this is an amber light. An amber light would be active surveillance. The patient is seen every 6 months, every year. but not necessarily subjected to surgery. So I agree with you. What we want is not over surgery. We want the right treatment approach.
Thank you for your comment. I completely agree with you. In Japan, we try to separate BRAF tumor and RAS-like tumor more accurately. I'm not saying 100% accurate. We are certainly more than 90% accuracy. We can separate RAS-like tumor and BRAF tumor. In BRAF tumor, we send them to the surgery, and they decide size of the nodule and the extrathyroid invasion or lymph node metastasis using ultrasound, and they decide surgery or observation for BRAF tumor. When we found a RAS-like tumor, we classify it usually into Bethesda 4 or Bethesda 2, benign or FN nodules, and let them observe by the endocrinologist. And when it grows, become larger, we further examine the nodule, more sophisticated image analysis. And when we suspect any invasiveness around the thyroid, within the thyroid nodule, we let them send the patient to surgeon for further diagnostic surgery or treatment for the RAS-like follicular thyroid tumors. Therefore, we have very few diagnoses, histological examination of RAS-like benign nodules.
Mm.
Did you follow me? In China, it is also done in China. In your histology, you have a large number of malignant tumors and very few benign nodules. Is that right, Dr. Go?
Yeah. In most hospitals,
you are very conservative approach to the FN nodules.
Yeah, this also depends on different hospitals. You know, there are some very well-equipped hospitals with very good pathologists. Then they can make a more precise diagnosis. And but in reality, also in some hospitals, they actually do not do FNA. They just based on ultrasound, and some of them directly go to surgery.
Yeah, in such cases, you have many papillary cancer in small size. More than 50% of surgery are small papillary cancer. That's too much for me.
Hey, Dr. Kakudo, just now you mentioned in Japan, the gene test is not covered by insurance. Then how did you determine which one is BRAF and which one is RAS-like?
Well, usually we do not have such data to feedback. But during the international collaboration, whose patients' molecular data is available, I found that papillary cancer I'm making diagnosis are usually BRAF type. And we don't have papillary cancer of RAS-like tumor very often, because we think it's follicular adenoma or follicular thyroid cancer, not a follicular variant PTC.
Okay, so basically your examination or your decision is based on morphological examination.
Morphology, yes.
Yeah, and then based on literature, and then you correlate, you name them as the BRAF or RAS-like subtypes. Yeah.
To make it clear to the Western authors, the papillary type, the papillary cancer I called is a classic type papillary cancer or BRAF type.
Yeah. So just now you also mentioned, and the Prof. Pong also mentioned, there are different thresholds when you make the decision, and probably different pathologists have different, maybe different judgments. Then mention an idea. I think this is very widely used currently in many diseases, like AI. So AI can also read images and make some decision, and it's widely used in some the eye disease diagnosis. In China, actually, last year, there are a few tests have been approved by
Oh,
the
really? The Canadian, let me tell you one funny story for you. One famous Canadian pathologist, Dr. Asa, this is a very dominant pathologist in Western society, sent me about 20 cases of papillary cancer, follicular variant, and asked me the diagnosis because they try to establish AI diagnosis of follicular variant papillary cancer. But 0 cases of papillary cancer for me. The cases all are either follicular adenoma or follicular thyroid cancer for me.
I see.
So that's very, very interesting. And the study was stopped because of the no consensus was obtained between among the pathologists.
Yeah. Do you know how many images have they used for the training of this model?
Ah, I see. I'm not sure because it was handled by other pathologists. I'm just an observer, one of the reviewers.
Yeah, I know. So do you think it's possible that this model definitely is not good? It's not good enough. So the model that they sent
the gold standard is very important. If a gold standard was kind of moving, diagnosis is not firm enough, you can't reach a good result. That's I think you can understand. If someone call it benign, the other one call it benign, that is not a scientific approach.
So the
Therefore, I recommend Dr. Sun to use the cases with cancer death and the cases no recurrence. That's probably you need. Few cases is enough. You can find a new observation because
it needs long-term follow-up. It needs long-term follow-up.
In between the two groups, we have many malignant tumors who do not recur, who do not kill the patient. How we should handle those cases are not yet established. Many pathologists call them all cancers. And therefore, 98% of patients after surgery do not die of thyroid cancer. Like skin tumors, like basal cell carcinoma. It's almost benign tumor, but called cancer.
So another question, also a second suggestion from Popcorn. So, now they are based on morphology and gene tests. But we know that protein also very important for the biology.
Yeah, I think so.
Now we start to publish a few papers in this field because it previously is very difficult to analyze the protein in a liver biopsy. The tissue is too small. Now we have the technology to analyze thousands of proteins from a tiny amount of tissues. So let's say in the next few years, we will try more. We're now collaborating with more than 20 groups in China who are expert in thyroid. We are collecting many samples from different hospitals. So we are studying the proteome of different type of these samples. And let's say, if let's say one day the protein test can be part of the guideline in the WHO book, in the book that you are writing maybe next week.
I'm looking forward to your result. One more advice I have is please divide the result in 3 groups. Definitely require surgical treatment, and better have removed to confirm morphologically. And the one who do not require any further examination or treatment. That helps a patient anxiety very much, I think. Well, we have to think about the patient more. When we made a diagnosis of thyroid cancer, even if we can tell her or tell the patient, this is very low grade, but the patient is afraid very much about the rare recurrences. Therefore, they apply unnecessary radioactive iodine or unnecessary neck dissection or total completion of thyroidectomy. If you can tell this is not necessary for this case, it helps patients' anxiety instantly, I think. Benign or malignant is not a good choices for the patient. I think we should divide into 3 groups. Completely benign, no further treatment is necessary. And the few cases should be examined in detail to confirm benign or malignancy. The other few groups are malignant tumor, definitely need surgery or further treatment, but it is difficult to save the patient's life, like poorly differentiated cancer or anaplastic cancer. And I would like to introduce, after this session, I will send one paper to you. There was a paper published last year about surgery refusal of the papillary cancer patient. It was about 140 patients, only 140 patients. It treated in, not treated in United States. And patient died only 6%. 10 years later, 94 patients survived with cancer. Only 6% of patients died of thyroid cancer. Therefore, harmless cancer exists more than 94%. That's surprising for the treating surgeons. Your surgery is not necessary for 94 patients, 94% of patients.
Yeah,
it's very impressive. I was surprised very much.
Yeah.
Can you tell how much patient can survive after surgery? They showed the treatment groups. Untreated patients survived 94% at 10 years with cancer. How about the surgery group? Can you tell how many patient can survive at 10 years? 96%. Only 2% of patients can be saved with surgery. That's surprising.
Yeah, it's really surprising.
Yeah.
And
4% of patients cannot saved even with surgery. That's a poorly differentiated cancer. And high aggressive cancer, papillary cancer or follicular cancer with distant metastasis, and anaplastic cancer.
Yeah, probably there are different thyroid cancers. If we
I think that's a rare cancer. Those are the rare cancer we should study, or we should develop our treatment strategy. But 94% of papillary cancer should be treated more conservatively, even if a safe option is necessary to treat those patients. We should not treat all of them. We should remain more conservative to 94% of patients. That's advice to Dr. Sun. Please separate 94% of benign prognosis thyroid cancer and 6% of thyroid cancer truly develop lethal malignancy. Did you follow me, Dr. Sun?
Yeah, following.
Tiana, could I just chip in here?
Mhm.
I think the discussion has taken a rather interesting direction. And as Professor Kakudo says, what really concerns the patient and her doctor is, am I going to die of thyroid cancer? And as Professor Kakudo says, many people who have thyroid cancer, in fact, die of something else. They don't die of thyroid cancer.
That's
So
true.
it is the number of people who will in fact be killed by the thyroid. That's the small minority that we need to identify early. Now, one of the challenges of doing thyroid cancer has to do with the fact that thyroid cancers tend to be rather indolent. I mean, some of them are aggressive, but many of them are indolent. And therefore, a prospective study is sometimes very difficult unless you start it at a very young age, because your patients will outlive you most of the time. So I'm wondering whether something that you and Dr. Soon could consider, especially because your technology can do whole proteome analysis on retrospective formalin blocks, right? You can do it on FFPE. Could we, for example, go to as many medical centers as possible and find those patients who actually died of thyroid cancer? This is what we call disease-specific mortality. They didn't die of a heart attack, they didn't die of strokes, but they actually died of thyroid cancer. Now, those are the patients that we should be interested in. And if we can get their FFPE blocks, and with your technology, it may be very interesting to see what was different about these cancers compared to a control group, which was similar in many ways, but died of something else. Because
I think it's a very good advices, Doctor, to Dr. Sun. I agree with Dr. Kon.
Yeah, we are collaborating with a few clinical centers. They have some rare cases, but very few people, they died from thyroid cancer. But we have a collective, I think at least 100 or more individuals. But we have one challenge, one very big challenge. So most clinicians, they think the pathologists are the gold standard. The WHO standard, there's several Chinese standards, and they think they should do surgery because of what's written according to a guideline written in the guideline. And now, actually, Dr. Kong, what she proposed is that we invent a new criteria. This new criteria, maybe we do not look at the morphology, but only analyze the molecules which are regulated between the samples from patients who died from thyroid cancer and those who are not. But they in current guideline, they have several morphology or genetic test-based subtypes, like undifferentiated thyroid cancers, and they think they are more likely, or most of them will die. And it's very difficult to change this. We know it's not perfect. The current WHO guideline is not perfect, but it's very difficult to change this. So I also want to ask Professor Kakudo. So let's say if there's a new way, let's say we've done this. We analyze a few hundred samples from patients who died from thyroid cancer, and some others
you can find something new.
Yeah, we can find.
In such a cases, please separate two groups into two groups: who developed anaplastic thyroid cancer and who remained papillary cancer or follicular cancer.
Yeah. Okay. So if we separate them and we find something new and some protein they are different, then
I believe so.
Yeah. So then what more experiment we need to do before we can convince pathologists like you that this should be a new guideline.
Oh, well, I'm happy to help you in any way. Many pathologists, even pathologists, believe the diagnosis of malignancy is correct. It is a correct diagnosis because the tumor has an invasion, tumor has a lymph node metastasis. However, many of them live longer than those who do not have thyroid cancer. That's the problem. Therefore, control subject, control sample should be small papillary cancer, not a normal control.
Yeah. So of course, if we find something new, then we must publish some paper, some peer-reviewed journals. And do you think, so what type of evidence do you think is authentical so that it can go to a guideline? Let's say if we study 100 patients, 100 pairs of samples. Is it sufficient, or do we have to include data from multiple countries? Let's say only patient in China is not sufficient. We have to include patient from Singapore, from Japan, from Australia, or even from the US, Europe, or so.
I think you can find several collaborators from other countries other than China. Yeah.
And how many patients do you think is sufficient? Just now you mentioned a study of 100.
200 is enough number. 200 is more than enough numbers. Probably the 100 patient who died of thyroid cancer is enough.
So these are from different clinical centers, let's say from different countries, from 3 or 4 countries, 200.
I'm not sure about this proteomic study affected by race background, genetic background, or something like that. Do you have any influences of racial epidemiological differences? If not, it is not necessary to find a variety of background. You can examine background racial effect, but I think the Chinese patient alone is good enough in a fast publication. Then you can expand your data applicable to other races like white and black or something like that.
Yeah. So in this study just now, Dr. Sun presented, we analyzed more than 500 samples from Singapore. 500 patients in Singapore. Singapore have different races. And the model,
mostly,
actually can be also validated in the samples from China. Some of them are not Asian, actually. Some patients in Singapore are Asian.
Well, I think Dr. Sun has a control samples already. Therefore, you need another 100 patient who died of thyroid cancer without anaplastic transformation. I think it's a most important field, follicular cancer and papillary cancer.
Yeah.
Dr. Liu, do you have another comments?
Oh, it's a pity that I didn't attend your research.
Well,
maybe in the future, yeah.
We should, do some collaboration, maybe after this meeting.
We talked about this topic before, but it is very difficult for me to get the washout or fine needle aspiration in my department. Yeah, but it will be, maybe it will be possible soon in about 1 month, because I'm talking about this with our dean.
Great. But for the FFP sample, I think Dr. Kong and Dr. Kakuda mentioned just now, I think we can do that. We can collect about 100 pairs of thyroid samples in FFP format. And part of them died from the cancers, part of them not. then we can identify the differences. And this maybe give some new insight to this field.
I think follicular thyroid cancer and papillary cancer has two different groups. The patient who developed recurrence and metastasis and died of thyroid cancer. And the other one is no recurrence. And the patient was survived without disease after the simple excision. But both are the thyroid cancer by the pathologist.
Yeah. So so Dr. Sun is doing another study. She collected over 300 pairs of follicular adenoma versus carcinoma. I mean, this is based on the pathology diagnosis. It's not based on survival or metastasis. Do we have metastasis data?
Yeah, we have the metastasis data, but we don't have the recurrence data.
It's very difficult to have recurrence data because this sample collected recently in the recent maybe 2 or 3 years. So we need to another 10 years.
Longer observation period may be necessary. Yeah.
Need long-term follow-up. So in fact, in your presentation, Dr. Sun, the proteome of follicular thyroid carcinoma is very different from papillary thyroid carcinoma. Yeah.
They are very different.
It's very interesting, It's very interesting because papillary carcinoma mainly metastasis.
Develop lymph node metastasis.
From lymph node metastasis. But follicular carcinoma is very different. It is mainly through blood vessel. Maybe there are some difference between the proteome profile.
Yeah, we also find some interesting pathways for the papillary thyroid carcinoma. The inflammatory signalings are highly overexpressed in the papillary thyroid carcinoma. I don't know why, but I find the evidence.
Okay, so Prof. Kwon, do you have any other comments?
Well, except to say that there's a lot of work to do.
We
still have a lot of work
you gave
to
her
do.
the new project.
Yes, and we must hope that the pathologists can agree among themselves so that we don't have to worry about it. We still want a gold standard. We don't want a bronze standard.
Yeah, so I think we are in the field of proteomics. Basically, proteomics is quite technological oriented, and the pathologist is very different community. So I have been trained in Zurich for 5 years. I attended a pathology meeting in Germany every year, and they are talking about completely different languages. So last year, 2 weeks ago, we had a meeting with my previous collaborator from Zurich. He's now Peter Wild. He's now in Frankfurt, and he also is a fan of new technologies. So I think these two communities should have more communications. I would be very happy to invite Professor Kakudo and Professor Liu to our proteomics meetings and present your perspective.
Yeah, thank you very much. I'm very interested in your study on proteomics too. Yeah, you can develop the new dimension, how to decide a treatment or not treat the patient. We hope, Dr. Liu and I hope you have a successful result to be published in the good journals.
Yeah, thanks so much. I think maybe we should publish more in the pathology journals so that the pathologists read our results.
Molecular proteomic classification of thyroid tumors.
Yeah, exactly. Thanks so much. It's already more than 1.5 hours. Thanks so much for your participation. And
it's my great pleasure to join this meeting, and Dr. Kun And Dr. Sun, I'm impressed with your discussion today. And
Thank you.
Dr. Liu, see you somewhere soon.
Yeah.
Thanks so much, everyone.
Thank you so much.
Yeah,
Thank you.
Yeah,
Thank
have,
you so
have a
much.
nice
Thank you.
day. Yeah, bye-bye.
Bye.